I hope you all can hear and see me okay. My name's Ita. I am a psychiatric pharmacist in the Republic of Ireland and help to coordinate the MHII network with our very own Dr. Jo Howe, who's joining us today and is leading this presentation, thankfully. Today, we are going to talk about non-pharmacological interventions to manage antipsychotic-induced weight gain. And we're going to have a particular focus on the implementation of those. And Jo has done some really, really important and I suppose seminal work with regards to how we actually implement these sorts of interventions effectively in our practice. And that's important because that's really missing from the research in this area, or was, until Jo very helpfully addressed that with a big or very large review that she's done and some other work which is coming out of that, and that's ongoing. And these sorts of studies, I think, are really important to answer a different set of questions to the typical research methodologies that we use in this area that look at what works in terms of average effect sizes. But as clinicians who are joining the call will know today, these sorts of interventions you'll intuitively appreciate work better in some contexts among some groups of people. So doing this type of research that looks at when are these interventions likely to be effective amongst who, in what context, is so important if actually the people that we look after are to benefit from them. So I'm going to do a very brief introduction for Jo, for those who are not familiar with her. So Dr. Jo Howe is a chartered psychologist whose research focuses on severe mental illnesses, particularly improving the physical health of people prescribed antipsychotic medication. Jo's work examines how weight gain is understood, discussed, and supported in everyday practice, and how services can better align with the needs of service users, carers, and clinicians. Jo has worked across a wide range of research studies and quality improvement projects in NHS trusts. Jo is currently collaborating with clinicians to develop a digital evidence-informed resources to support people in managing antipsychotic-related weight gain at the point of prescription, and has secured Health Innovation Network funding to develop this into a national resource for use across services. And that's something Jo is helpfully going to talk to us about today. Jo is also the founder of this very helpful network, the MHII network, which she plans to expand next year to provide a home for the growing mental health, physical health research and collaborative network she's involved in. Alongside this portfolio, Jo is recognized for her expertise in realist methodologies and provides consultancy, training and supervision through her company, the Realist Hub. She also holds an honorary visiting research fellowship at Aston University. Jo, before I forget to mention at the end, if people do want to look further into your research or reach out with regards to the work, the important work you're doing in this area, I think LinkedIn is probably the best home to find you in. Would that be fair to say?
It is, yeah, definitely.
Okay, yeah. Super.
Lauren, could you have a look for my LinkedIn profile and share it to the chat? I don't even know how you do that, but I'm assuming that it's possible.
I think so. Or I think if you actually just type in your name into the bar, because I've always, when they ask you for it in peer review.
Yeah, I think it comes up as Dr. Jo Howe, and it should come up. Dr. Jo Howe, the Realist Hub, would also bring it up as well.
Super. Well, look, in terms of housekeeping, and before I'm just going to hand over to Jo, as always, we encourage conversation, we encourage questions. So please do post them in the chat, or feel free to turn on your video at the end, or just unmute and ask any questions that you have. Jo will be more than happy to answer those. I know today we're focusing on non-pharmacological interventions. If people do have questions around pharmacological management and we have time, we might try to address those. If not, there are lots of recorded videos we've done before on MHII's YouTube channel, or you can post them within the JISC mail. So we do have a mailing list where people talk about different aspects of managing physical health, or we encourage that within SMI management. But if people have specific questions that they want to ask there, please do. So with that in mind, I'm going to hand over to you, Jo, if that's okay.
Thanks, Ita. Feels really weird to be here on the other side of the coin. But thank you very much. Expertly done. So it's interesting to hear yourself come back because someone else talks about you. Go, wow, yeah, I've done that. And yes, I now run my own company instead of working for a university, which is working out better than I thought it would. So that's quite an interesting way to look at it. So hi, everyone. It's nice to see you. Thank you very much to Ita for that introduction. I'm just going to start the sharing process. Can we see that? Has it come across properly?
Yes, I can see that.
Perfect. All right. So today I'm going to give you like a whistle-stop tour of some of the research that we've done over the last 4 years as part of the NIHR-funded Resolve study. And we have looked at antipsychotic-related weight gain in everyday practice. I'm going to give you a very very quick overview of the service user experience. And what I'm really going to try and focus on is how healthcare professionals are experiencing and relating to this weight gain from their own perspective, because I think that is a very interesting area that has not been very well explored previously. And I think there's something that we need to do about changing the conversation here. And I'm very interested in your opinion. So please do put stuff into the chat and join the conversation, and join the Gist Mail afterwards to help us work out how to do this. So very quick introduction. As Ita's already said, I'm a chartered psychologist. I've been working now in research for 13 years. And previously I have worked across a number of different healthcare areas, including stroke and brain injury. But my real passions are around service organisation, coordination, delivery, and mental health, and in particular severe mental illness. I am now, as Ita mentioned, the director of the Realist Hub, which is my company, which provides methodological support, and the founder of the Mental Health Network that you are part of today. And next year that will be expanded to encompass a lot of my mental health work that I'm now doing. So antipsychotic related weight gain, as we all know, is a particularly important and very knotty, difficult topic to be able to resolve. So we know that antipsychotics lead to rapid and significant weight gain, and we know that the drivers are complex. And we've got a video about this on the MHI YouTube channel, which I think is called something about Beyond the Scale. Perhaps Lauren can put a link into the chat, which is around how antipsychotics actually work at a body level to be able to work in the way to help with the weight gain. So we know that appetite changes occur, and we know that there's metabolic side effects, and that lifestyle challenges are all part and parcel of this, and they all have a role to play. And the consequences of the weight gain are serious. People go on to develop cardiovascular disease, diabetes, and metabolic syndrome. And we know that people with SMI face a 3.7 times higher risk of premature death, and a life expectancy of up to 20 years shorter than the general population. So what should be happening then? We know from an antipsychotic related weight gain perspective, we know we have guidelines, and this we'll be able to see in more detail on the recording, but I'm not going to go into all of these guidelines in detail. But we have guidelines that help inform the management of antipsychotic related weight gain. So we've got baseline, we've got monitoring, we know what we should be doing. People should be monitored. If you look at the psychosis and schizophrenia guideline at the top there, weekly for 6 weeks, and then 12 weeks, and then annually after that. We know we should be offering lifestyle advice, and we know that people should be having physical health assessments. There are guidelines. We've also got quality standards and frameworks that also help us work out how people with severe mental illness taking antipsychotics and their physical health, in particular their weight, should be monitored. We know that we're supposed to not just screen but intervene, and we know that we're supposed to be making sure that people are regularly screened as well. And we have a lot of people who have local protocols in their local NHS trusts as well around this topic. At a higher level, we have position statements from, say, the Lancet Psychiatry position, or even from the Royal College of Psychiatrists, who again say that we should be monitoring people, we should be intervening, we should be doing early intervention at the point of prescribing. And I've highlighted that one there because that actually very little happens. We know that lifestyle interventions should also be embedded within routine care, but it's become really, really difficult. Preventative action is routinely called for now, but very difficult to implement into practice. And that's kind of like the overview of what I'm going to give you before I get into Resolve. So Resolve is a 3-phased study. So in the first phase, we conducted a realist review, which I'm not really going to go into much detail today, but it is published for those of you that are interested. Then we did a realist evaluation, which is the primary data study. So I interviewed service users and carers and healthcare professionals. And I've synthesized that into 2 papers, which I'm hoping to submit this week. And as soon as I've submitted them, they will be then published as preprints, which I will share on the Gist Mail mailing list. So if you're not a member and you want to read those, it's probably advisable to join. And you will be able to see those next week, hopefully, if I manage to get them through the preprint process. Out of that, we're also going to be co-producing some recommendations with our service users that we've partnered with from the McPinn Foundation. So just very, very briefly, this is the realist review. It was published last year, although I think it's probably just come out again this year because it was published online last year and it's come out in print this year. And this looked at non-pharmacological interventions. So the actual interventions that service users had participated in. And we worked out how they work, under what circumstances, how and why. And we looked at 74 documents and we produced what we call context mechanism outcome configurations, but they're just explanations as to how and why various things happen. And from that review, we surmised that you need a good, trusting therapeutic relationship. You need to have early conversations about weight gain. And in terms of helping people, you need to be able to be flexible and tailor the interventions to the individual needs. And you need to work with them. So collaboration between service user, family carers, and healthcare professional is particularly important. Now, in certain circumstances, peer and family support can enhance autonomy. But obviously, as you know from working in this area, sometimes that doesn't always work out as well. Stigma can undermine any effectiveness, and the stigma can be carried out at multiple levels because you've got layering levels of stigma in this area. You've got a severe mental illness, you've got stigma from weight gain and obesity, and then you've also got any elements of intersectionality that you can add into that as well. So the overall conclusion is that strong therapeutic relationships and behaviour change strategies are central to being able to have any success in this area. And that's kind of like where we started at with the review. But what I'm really here to talk to you today about is the primary data from the evaluation. I'm just going to very quickly go over a couple of findings from service users, but what I'm really going to try and explore in a little bit more depth is those findings from the healthcare professionals, because that is what I really want to talk to you about today. So again, we have our CMOC1, which is just an explanation, as I said earlier. We've given this the title, and these are all service user led titles. So we're saying early on, tell me what medications may do to me. So this is a recurring theme for us across multiple research projects. Service users are frequently not informed of the side effects of their medication, or if they are informed, they don't remember, and so they're not re-communicated to them. And so what we are saying is that as healthcare professionals, we need to be providing information about the medications and the side effects at the time of diagnosis and treatment initiation. So when they are given these antipsychotics, we need to be letting them know that weight gain is a potential side effect. And not only that, we need to be letting them know how to manage the weight gain. If they are prepared, they are actually more likely to stay with the medication and stop taking it. We need to make sure they have sufficient time to process what's happening to them, and we need to allow them time for questions and discussion as needed. Now, we all know in the busy clinics, this can be really tricky to do. So in your services, do you have an avenue for people to follow up, even if it's not with the psychiatrist because they don't have time? Is there somebody else that they can go and speak to really get an understanding about the medication they've just been prescribed, about the diagnosis they've been given, so that they can work out how to incorporate this into their lives? And as I said earlier, this information needs to be repeated at regular intervals, again with discussion points. They need to have opportunities to be able to ask any relevant questions. And that's just in relation to one aspect, and we've got 12 of these. I'm only going to show you two though. So another one is listen to me, be honest, and support me in caring ways. And one of the ways that I have interpreted this is also as, basically I want to be treated like a human being. So, listen to me respectfully, don't dismiss me. Listen to my concerns about weight gain. The amount of service users that spoke to me who'd had initial conversations or initial avenues of inquiry from their behalf shut down from the healthcare professional because they were told that it wasn't important, that we'll come back to it later. Or that, in fact, I spoke to someone this week who tried to approach their GP about weight gain, and the GP told them that it was beyond their pay grade to be able to discuss that. So that means that any conversation that they have is immediately shut off, and they have no avenue to be able to pursue that. So what we're saying is, please listen to them. If they have concerns about their weight gain, then try and help them. Be honest about that. Be open and be supportive about the weight that they gain from medication, and about the impact that can have on their lives, because the impact it has on their body, on their stigma, on their own self-perception is quite huge. When you are discussing options with them, include them as an equal partner and help them navigate the care system. We're aware that currently there are very limited opportunities within healthcare services to be able to provide people with support for weight. So if you are thinking about referring them elsewhere, help them navigate that, whether it's with the local authority or whether it's with someone in the acute trust. If you're thinking about referring to a weight management service, help them work out how they can do that, or help them work out within their own environment how they could maybe think about increasing activity, or helping them with looking at their diet and other things, that they can help look at this from multiple perspectives. Managing weight gain in this sphere is really, really complex, and we don't have enough data to know conclusively what could work, what couldn't work, outside of the use of a couple of key pharmacological agents, which Ita can go into more depth. But what I really wanted to speak to you about today is the reality of caring for people with antipsychotic-related weight gain and the impact that has on healthcare professionals themselves. So, as in, you. So, if we look at the guideline expectation, so the NICE guidelines expect us to have early conversations at the point of prescribing. Now, what the results that our study have shown us is that these conversations are either delayed or avoided. And ultimately, this is due to confidence of the healthcare professional. You're often concerned about damaging the trusting relationship. You're often concerned that if you tell them about the side effects, they won't take the medication. And as a result, the service users are then unaware that weight gain is a risk of the medication. And in fact, I spoke to one person in our study who realised that olanzapine, which was the drug they'd been taking, caused the weight gain when they saw the advert for our study in the hospital. So this is also supported by wider research evidence. So it's not alone. We know this is an issue. So the articles there on the outside, the Lancet Psychiatry Commission article there by Teasdale has said that healthcare professionals don't know how to raise these conversations. And they also said Halstead, which is another report from the same series of the Lancet Psychiatry Commission, has said that early conversations are often missing. And Equally Well has said there's just gaps, there's informed consent gaps. So we know that there is a problem with this. And then the next one, if we look at regular monitoring of weight and metabolic indicators, so this again is a national problem. Monitoring of weight gain on just physical health checks are inconsistent across the country. And we have very unclear responsibility. So who is responsible for doing this, how and why, and that varies. So in some areas of the country, secondary care have taken back the responsibility for this, but in other areas it's the GP. And then sometimes it depends who was the initially prescribing person. If the initial prescribing person is the GP, then that means that some people can often fall through the gaps. Often service users receive no explanation or follow-up to their physical health checks. And I also know from work that I do outside of this, so I get involved in some teaching, is that quite often I've seen a lot of audits. I've marked a lot of clinical audits as part of a course that I'm involved in. And I know that there are lots of cases where irregular results are reported and not followed up. So we know we have some problems here around the regular monitoring, and the whole intervene, don't just screen is particularly important. And again, from a wider evidence, we know this is a national problem. We know that low uptake persists as well across the whole population in respect to actually the monitoring as well. So in terms of, we're supposed to embed lifestyle advice into care. And this is I think a very sweeping statement, and difficult to really understand what that means, because actually, as I mentioned earlier, we have very little evidence as to know what lifestyle advice to offer. And I think this is particularly challenging. So what I have found, and I think it's very difficult, and I think it's something that we need to explore more from a research perspective as well, but the healthcare professionals in our study that I've interviewed often did not see this as part of their care. This is something that falls outside of their remit. And the service users that we interviewed rarely recalled getting any advice about lifestyle support anyway. And again, nationally, it's rarely integrated. There are system level barriers associated with this integration. So again, if we look at and more guidelines, there should be a clear role delineation across mental health and primary care, so secondary and primary care. But actually, the reality is the lines are very blurred. There's a lot of uncertainty. And for the service user, what that means is they're getting very fragmented care, and they're being left to navigate it on their own. And they're supposed to know how to do that without really understanding the healthcare system. And let's face it, it's really hard to navigate through the healthcare system when you're inside of it, let alone trying to navigate through it when you're outside of it. And again, we know this happens. We know that there's poor coordination of care, and we know that there's diffused responsibility, but this all makes for healthcare professionals who really don't understand where their role ends and somebody else's role begins. And that means that we end up with a big gap where nobody's providing any care. So staff are supposed to be equipped to act proactively to help manage weight gain. And this is something I think is just not happening at all. So healthcare professionals were speaking to me about their lack of training in physical health generally, so not just in relation to weight gain. And a lot of them reported a lack of confidence in their ability to not only have conversations about weight gain, but then to advise on what they should do because of the lack of evidence in this area. So we know, again, this is something we're well aware of, that staff are underskilled, and equally well, charity have found that there is, again, low workforce confidence in respect to this area. So again, we look at the position statements from the Royal College of Psychiatrists. There's an emotional and ethical burden of caring for people with antipsychotic weight gain. And a lot of the healthcare professionals that I had conversations with described this level of helplessness. You know, we know what we should be doing. We know what we would like to do. We know the standard of care that we would like to deliver, but actually we are not able to deliver it. And that actually causes the healthcare professional a certain level of distress from their own side about the unmet needs that they can see that they are unable to help. And the result for the service users is they actually did feel abandoned. And again, from a wider supporting evidence, we know this exists, because we know that there's an emotional labour and ethical tension that exists in current clinical practice. So I've just got here, I hope it's going to work, some excerpts from the McPinn Foundation. And those of you who attended Aston, if there's anyone here in the audience who attended Aston back in March when we had our little conference, you will have heard this before. So sorry about that, but those of you who haven't will hopefully benefit from hearing. Now, these are individuals who were part of our lived experience group from the McPinn Foundation, who've been with us for our whole journey and who are commenting from their perspective around the impact of weight gain on themselves. If this doesn't, normally this comes across in the recording absolutely fine, but if it doesn't, Ita, please feel free to speak up and then I will voice it over. I'm going to try and press play again.
Not being told anything about the medication at all, let alone the fact that it may affect me physically. I was told nothing.
There was no mention of any side effects. No one mentioned to me that you put on weight.
He never talked about the side effect that was possible weight gain. It's only because I researched it myself that I began to read.
I don't think I've ever had a conversation about weight gain with a mental health clinician. It was found out by myself when I suddenly had gained the weight, but even then I didn't know why I gained it. I just knew I had.
I've had enormous problems trying to keep within a particular weight. I'd felt over the years that I'd had to trade my physical health for my mental health.
It's not just the physical impact. Self-esteem was low as it could have ever have been, and then to add the weight gain on top of that.
People have to not only battle with the physical reality and the mental reality of these things, but then also is compounded by the stigmatized attitudes, the intersection of mental health, psychosis, and weight is a triple whammy.
So something that affects us physically is important. It's not just about reducing mental health symptoms and giving us another problem.
I now look back and think, if I knew what I knew then, I would have changed my diet immediately and bought the gym immediately.
So I think that they're pretty powerful quotes, and these are things that we have been hearing from our service users over it's nearly 4 years we've been involved with them now. But when I spoke earlier about the stigma levels, you've got it here. The intersection of mental health, psychosis, and weight is a triple whammy. We are layering up layers of stigma which really affect people's ability to engage with weight loss interventions.
Not being told.
Right. So what I wanted to do now is give you a whistle-stop tour into the areas that can shape how healthcare professionals are able to support service users. And so we have three main areas that we can look at here, which is the systemic and professional challenges, the strategies that can be used to enhance individualized and meaningful support, and the role and limitations of non-professional support. So we're thinking here peer support workers and family carers and friends. So from a healthcare professional perspective here, we have healthcare professionals who have limited training and confidence to support both mental and physical health needs. So what comes out very strongly is that you want more physical health training, you want more confidence, you want more understanding of how physical health intersects with mental health. The current delivery system that we have of our healthcare professionals, of our healthcare services, so we have mental health and we have acute trusts, and they're very different, you know, they're very siloed. And this, compounded with secondary care versus primary care, means that we have very siloed systems, and these reduce the communication opportunities that you have with your colleagues from other areas. So for instance, it's quite difficult for mental health care professionals to not only liaise and talk to GPs, but it's also very difficult for you to have conversations with your counterparts in, say, weight management services. And this fragmentation of services and no real clear delineation between roles and, you know, services together, they don't really come together very well, means that this fragmentation leads you to default to your own remit, which limits the ability for holistic care. You can deliver care within the ability of the skill set that you have. You're not able to effectively get care from outside of that because of the way in which our healthcare system is organised and coordinated, and that is as a result of these inconsistent pathways, and we don't really have a very well integrated care within this country. Additionally, you add on to that organisational pressures, and I spoke to a few mental health nurses who had 400 people on their caseload. So the opportunity to give holistic, tailored support to individuals when you have 400 people you need to see every single month is actually very, very limiting. And over time, some of these lead to emotional disengagement and resignation. So I've spoken to people who've left. I've spoken to people who've transferred services to other areas, and I've spoken to people who are seriously considering leaving because they feel that it's just a battle that they cannot stay with anymore. So I've got here in front of us some quotes from healthcare professionals, which I think help sort of just bring to life some of the challenges that we currently face in caring for this population within our current services. I'm going to show you the next one. This is a service user one as well here. And if you look at the service user one here, it says that I think I've put on weight and being told, oh, that medication doesn't make you put on weight. All antipsychotics have been associated with weight gain in some form. We just have some that have higher risk profiles than others. I've also spoken to people who, I think this was a nurse in a clozapine clinic, and she said, so if we take clozapine as the example, and I'm paraphrasing because this interview was a number of years ago now. We know that constipation could be a side effect from clozapine, and we can do something about that. We know that drooling, so nighttime drooling, can also be a side effect from clozapine. We can do something about that. And we know that weight gain can be a side effect from clozapine. And when she said the other two things, she was looking directly at me because the interview was over Teams. And she looked down and she said, yeah. Well, we tell them that we'll deal with that later, but we don't. We never really deal with it at all. And on the paper, that comes out as just text, but actually what doesn't come out very well on the paper is her body language and the way that had affected her. You know that this is a problem and you feel very limited in what you can do to be able to help and support these people. So if we look at it something as a little bit more positive, if you like, so we know the reality of it, and it can be very, very challenging. So what we're trying to do now is trying to think of what can you do and what can make a difference in this space. So one of the things that came out through our conversations is the importance of co-developing a plan of action that is important to the individual service user themselves. And that I think is really important because it helps with motivation. Because if you, from a service user perspective, if you've got somebody who's motivated in something, they're more likely to see it through. We also need to get that therapeutic relationship, that the importance of that cannot be understated. And this comes through from various research projects that I've done over the past few years, especially in mental health. Trust is really, really fragile. So getting a very strong and trusting therapeutic relationship is a foundation to more success in the long term. One of the big things, proactive conversations around weight. I've spoken to a number of service users who were desperate to have conversations about their weight, but didn't dare bring it up because of how much shame and embarrassment they felt around their weight gain. So bringing that up proactively as healthcare professionals could help open the door to have some of these more meaningful conversations. And again, you know, these early discussions about the side effects, they are difficult discussions, but they are important. And if we can help prepare people for those, then that I think is definitely a benefit. So you do understand that amotivation is clinical and it's not just a behavioral response. So that I think again is, you know, outside of mental health, people can see amotivation as a, you know, a problem with the personality. And we do understand that in mental health, this is to do with the, not only with the diagnosis, but also can be a side effect of the medication, especially if you've got medications that are particularly sedative. And one of the things that does come out again quite a lot is the importance of routines to keep the change going. So this again is just a few quotes around the systemic fragmentation and how the lack of training can impact the care pathway. So you have mentioned here about the unclear pathways, how the fact you feel a bit unequipped, and these findings reflect how you try and find more meaningful support to service users because of the fact that you know that it's challenging. You're working in a really challenging environment, and we have a mental health service which essentially really needs some input from physical health, but that's proving to be very difficult to get. So you know the importance of tailoring care plans. It's not just about ticking boxes, but starting with what the person themselves wants to achieve and why that's important. And some care plans can be too generic, and that, you know, then that risks disengagement. So you do need to make sure that care plans reflect people's own needs. And proactive weight conversations about weight gain are really important, especially when we think about how quickly weight can be gained on antipsychotic medications. But the timing of those conversations is very delicate. And if you wait too long, then you risk reducing the trust that you're trying to build up. But equally, if you have them too early when someone is really, really poorly, then they may not remember them, which is why we need to constantly repeat these conversations. So there is a real ethical tension there, I think, between, you know, how and when to have those conversations. And, you know, the importance of building confidence and routine helps with motivation over time. So supporting people to find structure and starting very small and reinforcing small wins can help with a little bit with that motivation. So what I think is very clear at the moment is healthcare professionals want to work in this way, but it takes time, it takes skill, and it takes a system to allow you to do it. And these aren't always routinely available in routine practice. Oh, hang on. There we go. So if we move on to another area that we looked at, which is the role and limitations of non-professional support. So here we're talking about peer support workers, and we're talking about family and friends. And families were seen as potentially helpful. And I'm sure you can relate to this because you'll have had situations where family involvement has been really crucial, and you'll have also had situations where family involvement hasn't been particularly helpful. And families are seen as helpful, but only when the involvement is constructive and respectful of the service user's autonomy. So some healthcare professionals described to me how overly controlling or particularly uninformed family members can actually disrupt any progress that you're trying to make. Whereas in other situations, when you've got families that aren't like that, you've got families that can be really valuable partners. But there is an importance here that we need to give the right education and support to the families as well, to be able to help them give the right support to their loved ones. And again, peer support was consistently viewed as really powerful. I don't think I can actually really emphasize just how important this came, often having much more impact than any advice that you can give as professionals. You spoke about the strength of the peer dynamic relationship and how hearing from somebody with lived experience could actually achieve breakthroughs in a way that you couldn't achieve just by having that conversation on your own. So I don't know how many of you are using peer support workers, but they are seen as a really, really valuable resource within mental health. But peer support was consistently underfunded, inconsistently delivered, or peripheral. It's just separate to the core team. A number of people spoke about how it had been, used to talk about the good old days back in 2010 before austerity measures, how you had peer support workers in your own services and now they've been outsourced to charities. And that the charities don't necessarily have recovery or rehabilitation goals in mind, and therefore they may be trying to do something that may be at odds with what you're trying to do clinically. So there is a real difficulty at the moment about getting meaningful or consistent peer support as part of routine care planning. So there was a very, very real frustration here from healthcare professionals that this could be something that was so effective but wasn't being properly embedded within service delivery. So I think that's definitely an area for future research to look at as well. So again, these are just some of the quotes here around the roles and limitations of non-professional support. So they again reflect this the systemic fragmentation and how the lack of training can impact their care delivery, and how this, when it persists, that again, staff can become demoralized or emotionally disconnected. And these findings also reflect how healthcare professionals did seek to provide more meaningful support to support service users. So again, I think this is just like really, really important here. You know, you understand the importance of the peer staff, but again, it can be very difficult, especially where resources restrict the involvement of peer staff within the services. Okay, so despite us knowing all of this, what we do know is that conversations about weight gain often don't happen, or where they do happen, it's too late. And our service users in our research have told us that this is a very, very difficult space to inhabit for them. Healthcare professionals want to help, but often feel powerless in these fragmented systems. And this is kind of like the focus that I want to talk about today, because I think this is where we need to try and make a difference. We need to try and change the context so that we can start to help service users, and then we can hopefully end up with better outcomes as well. But what I wanted to do is give you another insight then into the hope for the future. So this is, again, going back to our lived experience members from the McPin Foundation, and I'm going to give you a little bit of a snapshot into why they think things could change because of the like of research that they've been part of. But there is other research also going on in this space. So we know that something needs to change, and there's hope in increasing research, you know, on the interface in between mental health and metabolic health and the management. And we know that that is an area of emerging interest. But anyway, I'll let you have a listen to this.
Because of Resolve and Leg, I know that I have to make changes to myself to help myself to complement the medication that I'm taking and so reduce some weight. And this is just giving me like a catalyst to try harder.
The comfort of knowing that there are other people like you. That's what one of the main things I gave in Resolve was learning from other people. And I think that ability to compare notes, as it were, whilst working on something that is actually, you know, a way forward, I think that's a really powerful thing. It's a real empowering situation.
It's helped with self-acceptance, which in turn helps with your self-esteem. I feel better about my own lived experience. It's been good to be part of a project that will have an impact on others that will be in a similar position to myself. And I can't go back and change any of that, but I can change it for somebody else.
Resolve is about, to me, it's about fighting back. It's about saying, I don't want this situation to continue. You know, if there's 3 people pushing at a door as opposed to 1, it's more likely to make an inroad, isn't it? So I think the impact is that it gives people a degree of hope and a degree of power that potentially they've not had before.
I would just love to be in that process that happens, for you to be treated as a person from the outset, which includes you both mentally and physically.
Okay, so I've given you a very, very whistle-stop tour, focusing on a couple of key points in the Resolve study. But what I think I wanted to say now is, so we've got our evidence, and so what are we doing? What are we doing about that? So we've set up this network, the Mental Health Innovation and Improvement Network, and at the moment the goal of that is to provide monthly seminars around physical health and mental health, to be able to help with some of the things that I identified earlier, so that confidence, that knowledge, and the skill set. I have also, I'm working with a number of trusts in a number of areas who are doing QI projects, primarily in around prevention of weight gain, but I'm interested in anyone who's looking at physical health. So if anyone's doing that, we're going to be doing a drop-in session next month, and we can talk a little bit more about that, but it's a drop-in session for people doing QI projects. I'm developing a multidisciplinary resource, which I'll come to in a few slides. I'm also liaising with the Royal College of Psychiatrists, and we've got a position statement coming out next year, and I'm working on a paper with them as well. And future funding applications, which have actually just found out last week, have been successful, one of them at least anyway. So we know what good care should look like. But at the moment, the systems, the training, and the structures are stopping us from being able to deliver it. And we know what you're trying to do. And we know that personalised care, early conversations, and peer involvement are important. So when we come to the conversation, what I kind of really want to focus on is, what do we do? What do we need? What needs to shift? What do you need? What would help? What do you want to know about this? So I really want to have a conversation around that. But before I do that, I'm just going to very quickly talk to you about the QI project. So I'm going to show you a booklet in a couple of seconds. And I will be seeking NHS trusts next spring to run their own QI projects and pilot this booklet in their own trusts. The booklet is in development right now and should be developed and should be finished by January, February. I will share more information, hopefully in December, around how you can join the early list for this. But hopefully I'll also talk a little bit more about it in December. So I've literally just copied this from another presentation. So some of the things haven't worked so well. But I am developing a digital tool to be given to people at the point of prescription to help them understand and give them lifestyle type strategies to manage weight gain. So we know that we have weight gain from antipsychotic medication, and we have weight gain that isn't from antipsychotic medication. And at the moment, the jury is out as to whether we can do anything preventively about either of them. So what I would like this tool to do is to do proof of concept to see whether, if we give people information about their weight gain, can we mitigate the amount of weight they might gain? Can we help them in any other way with their journey? So the booklet is, we need to do something different. NHS booklets tend to be, I don't know, how would you describe it? Full of knowledge, information. They're not very motivating. And so we know we need to do something that's different to what's commonly offered in the NHS. So we want a booklet that doesn't just inform, but truly resonates with people. We don't just want to give them a leaflet or a list of recommendations. We want them to engage, and we want to meet them where they are, whether that's emotionally and practically and physically. So if they are at the point of not leaving the house, that's where we want to meet them. We want them to feel seen, and we want them to see themselves in the material that we produce, because if they don't, they disengage. So we're creating this booklet. It's called the Future Self booklet, and it's designed to help people understand the challenges they're facing when they're on antipsychotic medication and build motivation to act early and on their own terms. And it's structured around 4 core pillars: clear information about how antipsychotics affect the body, psychological strategies like sleep hygiene and mindful eating, accessible diet and hydration advice, and support to increase activity in ways that feel doable. And in the other version, they all come up as different colours entirely. So I think that's the Aston template that's covered overall in that awful purple. So these images are from the current version of our booklet, and it's going through various iterations as we are co-producing it with some other people. So not the people you heard, but some other people from the McPinn Foundation. The design we've chosen has been deliberate. We definitely don't want it to look like a standard booklet. We want it to look like something you want to read. We want it to be more of a lifestyle magazine than a medical handout. And it's going to have pages in it that they can either write on digitally, or they can print out and write on themselves. We want it to be motivational, inspirational, and we want it to be non-judgmental and non-blaming. we want the booklet to help people understand why the weight gain happens, reminds them that it's not a personal failure, and helps them prepare for any weight gain they might gain through grounded and co-produced suggestions. And so we're hoping that it can help you, because we're hoping it can help support early compassionate conversations and to give both you and service users something tangible to act on, which is what everybody has asked for. So just a very quick thank you to the rest of the Resolve team. And now what I'd like to do is open up for discussions, of which I hope there are some, because I'd really like to have some at the end. There we go.
Thank you, Jo. That was great. I loved the service user quotes that you were able to put in. That's wonderful to be able to do that and to integrate. That was really meaningful. I really enjoyed those. I will ask people to post any questions that they have in the chat. I might just share a couple of my own reflections whilst people are doing that, if that's okay. It's funny, I was reminded of when you were talking about the importance of appropriate training for healthcare professionals and how often we feel is disenfranchised, perhaps the word. I'm thinking about my own experience. I remember one time, it kind of, I suppose, maybe being a bit of a shaming event for me in many ways, but it was when I was first working in psychiatry in 2016, and I had brought up about, I think it was changing antipsychotics. I had noticed from a plotted weight chart that someone was putting on a lot of weight with olanzapine, and I either had suggested something that was recommended in the Maudsley guidelines at the time, probably switching antipsychotics to a lower risk one, and that being in a multidisciplinary team meeting. And at that time in our service in Ireland, the service user would be present in the multidisciplinary team meeting, and we would all discuss the person's care with the person in the room. And that person, or the psychiatrist, I said that to the psychiatrist in front of the service user, and the psychiatrist saying to me, basically stop talking. We won't throw the baby out with the bathwater, sort of a thing. Weight gain isn't important now. Is the priority, exactly as you said, is the person's mental health, and me feeling very disempowered, I suppose, to help the person, and that we weren't working as a team when it came to weight gain. So I think collaborative training is really important, and that we all share the same values with regards to equity and health for people. But also the timing, it reminded me as well, the timing in which we bring up interventions and the importance of individualized care when it comes to weight gain, because we're correct, I think, in saying that for some people, when they are experiencing more severe mental illnesses, particularly psychosis, weight gain perhaps isn't the priority, but equally for some people, it is very important, even in those early stages. I remember when I did some qualitative research myself in this area, one quote really sticking with me from one person who said, I felt out of control in my mind with psychosis, but because of the antipsychotic-induced weight gain, I felt out of physical control as well, and that made things worse for me. So often we put it to the side, thinking that it's the best thing to do for that person, and it's not always. Or people often said to me, which highlights my own bias, I suppose, that I assumed that they wouldn't want to know about that, but lots of people with psychosis actually did want to be told about it at that stage. As you said, reinforcing it is really important, but still making sure we treat that person as a human. Informed consent is really important, that we don't make assumptions about people, as you said, with regards to choice of medications. But just so much of what you said really rang home and matched my own experience, which was great to see, and very encouraging for people in this area. Emma has asked a question in the chat, and she said, can I ask if the service user booklet is going to be used, I think, in inpatient settings, or what's your plan with regards to rollout and implementation?
So currently, the current model, so I think the psychological strategies element, the medication advice element, and the diet and hydration could be relevant, but some of the activities that are suggested within the booklet could be tricky to do in an inpatient unit. That's something I probably need to have a think about and a discussion with, because it could be that we need to be thinking about tailoring it or talking to you about it. But I think there are certain elements of the booklet that could be used, and we've already been asked, because we've secured Health Innovation Network funding to pilot the booklet next year at a NHS trust, Midlands Partnership Foundation Trust. So it'll be a big evaluation up there. And they've asked us if we can develop a strategy for primary care as well. So how would we get this to primary care? So at the moment, the booklet will be embedded in the Choice and Medication website. So it'll be available to everybody whose trust has subscribed to that. So theoretically, and if you're part of that, you could actually see it. But what we would like you to do, if you are going to do it, is collect some data for us to help us, because actually, preventatively, we have like no evidence for managing antipsychotic related weight gain, or for mitigating antipsychotic related weight gain preventatively. I know there's the metric, it's the metric, isn't it? The Paul French's study that's going on at the moment. So that will give us some information on using metformin. But there's just nothing out there that says if you do these things preventatively, it can help. Now, I think when you're talking about weight, that can be tricky anyway, because you can have situations where weight can still go on, but maybe they don't put on as much. And that is going to be tricky to evaluate, I think, because obviously you're then looking at still putting weight on, and that might still be demoralizing to the person who's putting weight on. So we do need to get an understanding of just how much weight people do put on. And that would have to stratify that, I think, across various categories, including antipsychotic and gender and age and everything, and starting weight, etc. But yeah, Emma, I think that's probably a good question, and it might be that you'd need to see it when it's finished to work out how appropriate it could be. I'm just going to reach behind me because the dogs, I think, can sense something and are barking at something outside. So let me just open the door for you.
It's almost lunchtime.
It is very much that at lunchtime, sure.
Does anyone else have any other questions that they want to ask?
Or comments, or what do you need? What help do you want? Do any of these findings that we've got, do they resonate with you? Do you feel like you need more training? Do you feel like you need help? Do you know, or do you feel comfortable or confident in having conversations about weight gain? And that came up again and again and again in our research. You can never really be sure if if silence is a good thing in these situations, Ita.
I know. And it is, I think it is really challenging because some of the points that you said with regards to the importance of individualized, tailored care, and that it's built collaboratively as part of relationships, they all take time to do. So and
I think that creates a big tension. And these are kind of things that I really want to try and see. How can we work through some of this? We're not going to come up with a magic solution overnight, but how can we work through some of this so we can change some of this underlying context to help? Maybe is it around helping people have more meaningful conversations about weight? Is that what you would like?
Andrea has asked a question, you might call Andrea, but which healthcare professionals did you talk to? As a dietitian, I'm frustrated that everyone else is responsible for talking about weight gain, there are in inverted quotes, but as a dietitian, we are not considered.
So Andrea, Andrea, I would say Andrea, perhaps you'd say Andrea but I think Andrea sounds quite cool in Ireland. So this is a really interesting point. So quite a lot of the time what came up, if I was to say healthcare professionals identified gaps in MDT composition, there are two disciplines that would come up consistently, and if we had more time I'd ask you to put it in the chat, but we've only got 7 minutes left, so I'm sure you can guess that dietitian is one and psychologist was another, and they were the healthcare professionals who wanted more input. Now in some of the mental health trusts they didn't actually have access to any dietitians at all. They were in the acute trusts, and those that did have access to dietitians, the dietitians were also resource strapped themselves. And speaking to dietitians as part of our study, one of the things that came out very strongly is that in resource strapped environments, they go and place their resources to the greatest clinical need, which at that point in time is usually people who are malnourished or anorexia. So therefore, those people with weight gain are considered less of a clinical priority because their risk of death is not imminent. Whereas in other parts of the care pathway, so primary eating disorders pathway, that's where you're more likely to find the dietitians. So dietitian, I say, is a really interesting one, and I would say it needs to be more integrated within mental health care normally. I mean, I'm really curious, like, where do you fit, Andrea? You turn your mic on and just let us know, where do you fit in this pathway? Are you part of a mental health service as well?
Yeah, sorry, I was just trying to type a response, but yeah, I was going to say we have 2 part-time dietitians, so there's I do 26 hours and I've got another dietitian. There's another dietitian works in the trust who does 32 hours. That's for the whole of Kent. And that's just inpatients. And I just feel that a lot of it should be done in the community, but
Yeah.
the community services don't necessarily have dietitians, and then they're being signposted to online stuff and Weight Watchers, and it's just not suitable for our patient group.
Exactly. And it comes up again and again. I mean, I had nurses saying, well, I tell them to do the Michael Mosley 5-2 diet.
Yeah.
And I thought, where'd you get that from this morning? You know, the TV show. And you're like, is there evidence for that? I don't know. But you know, so they're trying to help, but in a way. So that's why I think we need to help people with, like, this is what you can do. These are the things that you can do. So the booklet that we've got will hopefully have a section on, I don't know, healthy food swaps, you know, so you can actually, because I think it's really important that the antipsychotic hunger driver is satisfied, you know, because quite often a lot of the advice that was given is like, eat less biscuits, for instance. So eat less, move more. If it worked, we wouldn't have a problem. And eat less in this population with a biological hunger driver driving that, you know, hunger behavior is unlikely to be very successful. So we do need to make sure that people are full. And then we can disentangle as well hunger and cravings and consider them as separate things. So you might be able to use a psychological strategy to manage cravings, but you're unlikely to use a psychological strategy to manage hunger. And I think that's important. But knowing what does work in this population is something that I think is sorely needed as well.
But I also spoke to someone on the ward this morning and I was saying, yes, ready meals are fine, frozen vegetables are fine. And she's had so many other people saying, oh, no, you shouldn't be eating those, they're bad for you. So I think the advice that we're giving has to be practical. It's got to be easy for people and practical.
Yeah.
And
I think one of the things, so in the booklet, we were just talking yesterday with our service user book. So we've looked at the physical activity bit and we're moving on to diet and exercise, diet and hydration next. One of the things they asked for were like suggestions, you know, easy suggestions that they can do. What can I do at home? Give me some tips that I can go, oh yeah, I could do that. You know, don't give me an elaborate menu that requires me to go and spend £20 on ingredients that I'm never going to use again. Give me something that I can do at home that helps me manage this. And it can also, I think, help with carers. So even if the service user, if they're in a supportive family environment and they're not well enough, then maybe the carers can also help to, you know, to make sure. So I can see that we've got Emma in the chat as well as doing a PhD on antipsychotic-induced weight gain. Wow, you're welcome to Eater and I Club there. That's a good club to be in, isn't it, Isa?
Yeah, I just finished one on, I just finished a PhD on antipsychotic-induced weight gain. I'd love to hear what you're doing if you want to post it. Emma is sharing her experience, I suppose, with the work that she's done with service users. So what you've said as well completely resonates with her with regards to what her participants have said about not being told about weight gain when they're started on antipsychotics, and then, like you just said, Andrea, having to do your own research on it, which is, you end up finding the predatory sort of stuff, especially at the moment, because weight gain and weight gain management with regards to medicines is so rife in conversations. I just had a baby 7 weeks ago now, and even on my own social media feeds, I'm constantly being sent stuff at the moment with regards to how to lose your baby weight, like all these videos of these ridiculous diets, you know, exercise advice, all these sorts of things, and it's not focused on nourishment or those sorts of things, or, as you're saying, practical advice. So yeah, people will go and find their own. But thank you for sharing your experience, Emma. Katie, hey Katie, just speaking about how menus are not tailored, of course, according to the needs in the NHS trusts, which I know is something which comes up all the time here with regards to food that's available for our services.
It came up a lot. So we interviewed people who were in the delivering care in the community and in the hospital, and hospital menus came up again and again and again and again and again and again and again. I'd love to do some research on that. That would be fantastic, because really hospital menus are designed usually for people who are malnourished. I always think about your frail old lady that needs building up, not for people who are trying to manage very difficult antipsychotic weight gain. They are usually cheap. They're quite often bought in. They're full of carbs. They're not usually very balanced either. And you get a pudding with every meal, even breakfast. They can be very, very calorific. And I know there's a lot of people who've tried to do something and just had so many systemic barriers, like organizational problems, in trying to get the menus changed. So I love to kind of get some sort of call to action. And that would be a great output from this group. If we could get a group together to try and work on something proactively to get hospital menus coordinated, that would be fantastic.
It's the same way with shops, isn't it? Like what's going on with regards to even in my own hospital now, our menu is better. But from what it sounds like, but like 2-liter bottles of Coke and stuff like that, like you're dangling, like you're not making it easy for people. It has to be easy with regards, as you said about the amotivation. People often are experiencing sedation, cognitive impairment due to the illness, never mind due to actually the medications that we're often given on top of that. So it's so difficult.
Emma, you probably also need to contact Charlotte Lee, or at least read Charlotte Lee's work. I think you'll find that very interesting. There'll be a big overlap in what you're looking at in relation to what Charlotte's doing. So yeah, have a look at that.
Yeah, the behavioural determinants associated with what external are currently changing.
Support comes out across all of our work. So your work, Charlotte's work, our work, people need more support.
Yeah.
So if anyone wants to ask me questions, I'll stay on for a few more minutes. Hi, Katie.
Hey, Katie.
Nice to see you again. But thanks everyone for turning up.
Thank you, everyone. And as we said, if anyone does have follow-up questions or things they want to ask her, please do put them in the MHII network or the email thread. Or Zarna shared that, thankfully. But otherwise, lovely to see you all. Thank you to everyone for your time. See you soon.